So TUGS endoscopy is one of the chapters of TUGS, and it has been started with the aim of promoting GI endoscopy among surgeons, specifically focusing on endoscopic procedures in the management of surgical diseases and creating a platform for learning GI endoscopy. So basically, it is all about endoscopy for the surgeons and by the surgeons. Now, today for our second academic session, we are honored to have a group of erudite and accomplished speakers and panelists, which includes both surgeons and gastroenterologists. So as usual, we'll be having 3 talks today, and they will be followed by a Q&A session and panel discussion. So now I invite Professor Subhash Khanna, and his talk is on the endoscopic management of hepatobiliary emergencies. Sir, the screen is yours. So please unmute yourself.
Okay, am I audible?
Yes, sir. Loud and clear. Please go ahead.
Thank you. Thank you. Thank you, TUGS. Thank you very much, Dr. Bhalla, for that kind introduction. I am given the topic of speaking on endoscopic hepatobiliary emergencies. I am Professor Subhash Khanna, a surgeon, a robotic surgeon, and my main interest is today a robotic and minimal access surgery, but endoscopy has been a passion of mine. And since 1996, I'm doing therapeutic endoscopy, mostly ERCP. When I was giving this topic, I just thought I would like to share a small quote by Emily Dickinson. Surgeon or an endoscopic must be careful when they take the knife. Underneath the knife and underneath the fine incision stirs the culprit alive. The topic is very wide. When we say emergencies and hepatobiliary, I think I don't need to enumerate all the conditions where an endoscopist is needed. What I want to say, starting from CBD stone to pancreatic leaks, to CBD strictures, to malignant stricture of CBD, to a CBD stone in a pregnant or a small child, to the parasitic diseases, to the idiopathic pancreatitis where there is no cause found, to the malignancies, the pancreatic necrosis, the hydrolysis of the liver, and endoscopic drainage of the pseudocyst. It's a very, very vast subject. What do we understand by this is endoscopy has taken a much inroads in surgery, and many of the conditions have become amenable to endoscopy today. In the time permitted to me, let's say what some of these, what we can take up now. Well, once again, I'll start with a surgeon, McCune, who in 1968 gave us the first use of endoscopic when he did cannulation of the ampulla of Vater, and thereafter there was no looking back, with lot of refinement in techniques, lot of new accessories coming. We have come a long way today with the addition of image enhancements, what Dr. Viparoy had shown, and with the additions of lot many gadgets, we are able to do much more advanced work. Dr. Viparoy, I thought, has already said what I want to say, where I understand many general surgeons who are yet to start ERCP or therapeutic endoscopy must be watching here. So a quick advice: if at all you want to start therapeutic ERCP, and if at all you want to attend the emergencies, you should be ready with a complete OR, with an anesthesia machine, a completely trained team, and also an anesthetist with you. You must have a suite with wider doors so that any patient coming in can be trolleyed in. When we look at the major common bile duct problems, we always have thought that common bile duct is a conduit. So when we talk about hepatobiliary and pancreatic problems, the CBD comes first, and CBD is not only a conduit, between the liver and the intestine. It is surrounded by pancreas. It has so many organs around it. So the moment any other organ is affected, CBD is affected, whether it is the ampullary mass or anything of that sort. Similarly, the common bladder problems are also very complex. It is very difficult to dissect the CBD from starting from conventional surgery. We have moved to open and to robotic surgery today. So CBD may be affected by congenital, traumatic, inflammatory, neoplastic, and obstructive lesion, and all of these cause different types of jaundice, different types of cholangitis, and different types of problems. And most of these are amenable to endoscopy. Let's see one. When we are talking about the ERCP and a patient in an obstructed jaundice, we need to know a little bit about sphincterotomy, whether I should be doing a sphincterotomy or sphincteroplasty, whether I'll be using a balloon or a basket. Sphincterotomy was a standard of care, and even today it is popular, but no one wants to leave a permanently damaged sphincter. So balloon sphincteroplasty has come a long way. Whether I should be having a high risk of pancreatitis if I use a balloon, whether it is more bleeding with a balloon, it is not. But then what is a strong indication, even if I don't want to use a balloon, when I should use a papillary balloon dilatation, at least in coagulopathy, in CLD, and in pediatric patient, when I don't want to cut a sphincter, I would love to use a balloon. When you want to start an emergency in the biliary tree, you must be prepared with all types of cannulas, both 5 French, 10 French, because you do not know in which stricture you might need a 3 French tip, papillotomes, both rotatable. You must also be prepared with needle knife, with different types of guide wire, 0.035 or 0.025, Dormia baskets, CRE balloons, and on top of this, the injection in 1 in 20,000. But the most important is this instrument, which I always say, keep one Soendra detector with you. Whenever you are stuck with a basket, you might need to use this. Okay, so when we want to cannulate in an obstructed duct, we either use a standard technique where we can go inside with a catheter or a papillotome. Today, the papillotome is more popular because in a papillotome which has a tip of 2 or 3 centimeters, depending on what papillotome you are using, you can always go it and give a direction to the tip. Needle knife pre-cut, I'll just show a video if time permits, is good when there is a stone impacted at the papilla, and when you cannot pass the cannula or the sphincterotome, or you cannot calculate, you can always prefer to go for pre-cut. But then if you have to understand what is pre-cut and what are the basic guidelines for that. Pancreatic guide wire technique is also important in case you are going frequently into the PD, which is straight at 12 o'clock or at 3 o'clock. Then you might have to sometimes put a guide wire there so that you don't go in hitting the PD time and again and then end up with pancreatitis. Okay. So most of the cases, the papilla is very plain and simple. You can see here, although it is very simple, there's a small diverticulum nearby, and diverticulum are always problematic. We have to understand it is a papillary diverticulum or is a periampullary diverticulum. And any endoscopist has to understand the direction of his guide wire and the sphincter insertion. So just for the beginners, we always nowadays don't inject the contrast. We go in, we both in the non-obstructed and obstructed duct, we put the guide wire. We are sure by looking at the guide wire that we are not in the PD with the CBD. Then only we inject the contrast once we have gotten access. Without getting the access, you don't inject any contrast at all. At times, the patient may come to you with a very flat papilla where you may not be able to cut it, and you may have to do a guide wire cannulation. Here we did a guide wire cannulation, as you saw, and even before we put this sphincterotome, the guide wire was inside, and we could do that. Coming back to some of the difficult cases where you want to do avoid papillotomy, you may make a small cut at 11 o'clock so that when you do a papillotomy, your papillotomy doesn't make a very rough dilatation and trauma to the papilla. I think we'll not go to the steps of the ERCP. I'll just go and we go to the emergencies. Septic cholangitis is present is almost 19% of the patient with CPT stone. These patients they need endoscopic decompression immediately. Even at times you may have to do a bedside decompression. The most important thing is if the patient is really seriously ill, we should not try to remove the cal. This is one patient where we wanted to just put a stent, nothing else, because he was having a separative cholangitis, where I had to do a pre-cut because the ampulla was not accessible. And you can see we have done a pre-cut with a needle knife and just put a stent without looking into the CBD, whether we have just confirmed the CBD by passing a guide wire. Suppurative cholangitis may present like this. The moment you are inside the duodenum, you might see the frank pus coming out from the papilla. In this particular patient, we were lucky that the stone, although as a caveat, I don't want to attend, but it just came out on its own, although it was very large, and the patient is doing fine. This patient I operated because there was this webinar only. I took up this patient who had deep obstructive jaundice. We took him on the 2nd of June, and we could not proceed further because his papilla was very bad. We did a pre-cut, and this is to say, do a pre-cut, go back after 48 hours. Then again, yesterday I went inside, and you can see I'm injecting the air, an air cholangiogram, no contrast being injected there, and you can see the thick bile, dirty bile coming out. The first thing when you do in all these cases is take a bile for culture, and thereafter don't try to take out the cal. That's what we have done, and we are putting a stent over a guide wire, and that's it. So suppurative cholangitis, try to do stenting within 48 hours. Do not delay. Improve. In case you fail, then you must have all the armamentarium, your intervention radiologist. In some of our cases, our intervention radiologist, they immediately do an antegrade stenting and take out the by PTBD, and then later on you can always do an internalization in case of malignancies where you want a permanent stent, and even a metal stent can be put from by the intervention radiologist. Biliary decompression by nasobiliary catheter in acute suppurative cholangitis. There are many studies, and most of the studies they say that if done within 48 hours, it reduces the mortality by quite significant percentage. Large common bile duct stone which cause obstruction may be treated with a simple ERCP, with mechanical literacy. But today, as my standard treatment, or the stringent treatment standard recommended is cholangioscopy and laser literacy if you have. Otherwise, you may be lucky to be able to do a good wide sphincterotomy, provided the papilla is very good. And if your luck permits, you may be able to take out a large cal also, as is evident in this case. We never expected that we'll be able to just take it out with the help of a Dormia basket. And this was a large 3 centimeter obstructed cal in the common bile duct. Such cal you mostly get in choledochal cysts, and thus it just came out. Patient again, I did yesterday, had an open surgery, failed open, ended up with a CVD cal and also a remnant of the GB. Now these patients are very tricky. He was not deeply jaundiced, so we went inside, did a balloon sphincteroplasty, and we have taken out the cal and have not put a stent even because after the completion cholangiogram we did, it was quite clear, and he needs cholecystectomy again. This is yet another emergency which you will be getting. Large CVD cals plus the intrahepatic stones today are managed mostly by spirocholangioscopy. If time permits, I will just share some of the images of the spirocholangioscopy. Intrahepatic stones, usually there is an intrinsic disease that needs to be treated, like Caroli's disease, or recurrent pyogenic cholangitis, or there might be a portal biliopathy, which itself is a different subject and which might be present to you as a human. Here, endoscopy's role is always there. You might need to stabilize the patient. If the patient is going for surgery, you may have to go for refer him to surgeon or to yourself, in fact, for surgical resection. And if that is not amenable percutaneously, the cholecystoscopically, it can be drained. Traumatic is the next common category of patient which come to us with an emergency, where there's a blunt trauma or a trauma caused by the surgery in cholecystectomy, CBD exploration, or gastrectomy or pancreatic surgery. They need, depending on the stage or as per the classification, you can make out A, B, C, or most of these patients can be treated by the endoscopist, except those having a hilar type E or type E1, E2, or some of those having a complete hilar cutoff, where there might be little issues with that. This is one patient who came to us, has a you can see the contrast. I'm sorry for image, and then you can see the the contrast is leaking. This patient need a simple endoscopic intervention. Just put a guide wire and put a stand there. Yet another patient who is just done yesterday, day for yesterday, as a large stone and also a remnant GV here. So we have just gone in and put our stent and without removing the cal. The patients coming with malignant obstructive jaundice are usually malnourished. They are dehydrated, they are septic, they just need a temporary decompression. They don't need any major intervention. They need to be corrected. For decompression, we have different types of stents, plastic stents like Teflon, urethane, and dilating catheters, balloon for dilatations. And these are the different types of stents which you can use depending on the requirement of the patient. A simple stent in a leak, which I have showed, is a simple plain Amsterdam stent, or you can also use a pigtail stent. We prefer using a single pigtail stent to avoid upward migration. So this is one long stricture in the patient post cholecystectomy ischemic stricture, where we have put a stent pending further evaluation by the patient. SEMS can be, they're very simple steps of putting a SEMS. You can see a stricture there. This patient coming from Arunachal Pradesh had a stricture in the upper at the junction of CSD and CBD following a surgery. Interestingly, this is a benign stricture, and we opted for a covered stent for this in a benign condition. And that's how, for the juniors, they can see how the stent can be put nicely across the stricture. Although it's a benign stricture, but still you can put a stent, and these stents, although they seems to be permanent, but they can be removed. Now, these are the patients. This was one patient where 3 attempts at ERCP removal of the stent failed because the stent was left by him for 1.5 year. So I just thought that I'll show you this. This is what the stent will come back from hard after 1.5 year, and I had to remove it with the help of my robotic surgery. Ascariasis and other types of parasites, including echinococcus, is very common. What we used to do was this: we used to take it out with the help of either open surgery or with a lab CVD exploration. But then you're never sure. Today you have done, tomorrow another parasite, another Ascaris lumbricoides may go in, and this is the classical picture of whatever patient we get. Ascaris is almost endemic in Kashmir, where Professor Khuro has presented a lot of work, and you can always go in, take out the Ascaris with the basket, never try to touch with the snare because it tends to cut through. Ascaris, you may also, I think, sometimes it is lost, as it is in this patient. I had to do a pre-cut. I went inside, and the Ascaris was, or the round mob was inside the converter, which I could see with the help of a spy camera only. So a spyglass may be of help, and later on, once I have visualized, it just came out on its own, and we had to drag it out. The hydrated cyst may rupture into the common bile duct, and you may have to take it out and flush it. And looking at the communication with the bile duct, you may have to put a stent there. I'll just go because time won't permit. Kapila, I think we have spoken about the balloon dilatation here. Okay, last few words about spirocholangioscopy, which has come as a big way, particularly both for stones and also for malignancies, where a breast cytology may give you only 50% positivity, and with at least more than 50% patient undergoing surgery without being a proper diagnosis. So you can visualize the inside the common bile duct. You can visualize the hepatic ducts. You can biopsy with the help of a spioscope. That's how a normal duct looks like, and you can always go in and visualize the hepatic ducts and take a biopsy from the actual lesion where you want to. A malignant looking lesion may come out to be benign, and a benign looking lesion might come out to be malignant, because a breast cytology may not be enough in such cases. For a spirocholangioscopy, what we do, we initially, nowadays we have started dilating because it's very easy for the spioscope to go in, and then although it is a single operator, we need a 30 or 20 watts laser, quantum laser, and then before you go in, we have as you saw, we have already loaded the laser in the scope. Otherwise, sometimes it doesn't come out, and once you are inside with the laser, you can do a lithotripsy. I think time won't permit for me to, let me just see. One more use of spioscope is sometimes you need to assist your surgeon on the table when he's lost. He's confused whether they so take your camera in through the CBD and can visualize the common bile duct and check they do a lithotripsy there. On-table cholangioscopy. Video is not running, sorry. So with the help of laparoscope, also through the epigastric port, rather than take microscope or taking any other rigid telescope, you can also go in.
I think there is some connectivity issue with Professor Subhash Khanna. Let's just wait for a couple of seconds and see if he can connect back. Yeah, I think he lost his connection there. So I believe he was almost towards the fag end of his presentation.
No, I am connected through the other system. Dr. Phalla, can you hear me?
Yes, sir, we can hear you, but we can't see your slides.
Sorry, my slides are, I'm not able to open it now. So I'm just another system. I'm sorry. Okay. So what I wanted to say in with conclusion, because I might have missed one or two videos were very interesting, where we use endoscopy for both in open surgery and also in robotic surgery, and also in different ways, which I wanted to share, but somehow there was a problem in the other system. So what I want to say is an endoscopist has a role in all hepatopancreabiliary emergencies. It's a vast subject. It itself is a subject that needs to be looked into. We might have specialists only looking at endoscopy for hepatopancreabiliary tree. Thank you very much.